Hello everyone, and welcome to today's live broadcast, Growth Hormone and the Adult Skeleton, presented by Dr. Nicholas Tritos. I'm Susie Valdez of LabRoots, and I'll be your moderator for today's event. We're excited to bring you this educational webcast presented by LabRoots and sponsored by DiaSorin. DiaSorin is a global leader in the field of biotechnology with a presence to over 80 countries. For over 40 years, DiaSorin has been developing, producing, and commercializing worldwide reagent kits for an in vitro diagnostic market, in particular for the immunodiagnostics and the molecular diagnostics segments. DiaSorin's products are specifically designed for hospitals and private testing laboratories. Their product menu is unique for the width and presence of specialty tests, which identify DiaSorin as the diagnostic specialist. For more information about our sponsor, you can visit their website at www.diasorin.com. Before we begin, I'd like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time during the presentation. Just click on the green Q&A button located at the lower left of your presentation window and type your question into the box that appears on the screen. We'll answer as many questions as we have time for at the end of the presentation. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the CE button located at the bottom left-hand corner of your webpage and follow the process for obtaining those credits. Also, please notice that you will be viewing the presentation in a slide window. To enlarge that window, just click on the screen icon located at the lower right. If you have trouble seeing or hearing this presentation, please click on the support button at the top right of your presentation window, or use the Q&A button and let us know you're having a problem. I'd now like to introduce our fabulous speaker, Dr. Nicholas Tritos. Dr. Tritos is an associate professor of medicine at the Harvard Medical School and the pituitary endocrinologist at Massachusetts General Hospital in Boston. He's a graduate of the University of Athens School of Medicine and Harvard Medical School. He completed his center residency in internal medicine and fellowship training in endocrinology at Beth Israel Deaconess Medical Center at Boston. He has authored and co-authored over 110 publications, including peer-reviewed articles and book chapters in his field. He serves as an associate editor for the endocrine practice and an editorial board member for several endocrine journals and a peer reviewer for numerous endocrine and other medical journals. Please join me in welcoming Dr. Nicholas Tritos. I will now turn the presentation over to him. Welcome, sir.
Thank you, Susie. Welcome, everyone. I'm Dr. Nicholas Tritos. It's my pleasure for you to be here today. The title of my presentation is Growth Hormone and the Adult Skeleton. Here's my disclosure slide. The objectives for this presentation are to discuss the physiology of growth hormone secretion and the diagnosis of growth hormone deficiency or excess in adults, review the consequences of growth hormone deficiency for the adult skeleton, and describe the sequelae of growth hormone excess on the adult skeleton. Here's the outline of this presentation. We will start with a historic overview, then discuss growth hormone secretion and action in brief, proceed to the diagnosis of growth hormone deficiency and growth hormone excess in adults, the latter is known as acromegaly, and then review the effects of growth hormone on bone tissue. Finally, we'll be discussing the consequences of growth hormone deficiency and growth hormone excess for the adult skeleton. So it was over 100 years ago that Harvey Cushing, the famous neurosurgeon, postulated the existence of a growth-promoting substance produced by the pituitary, and this was based on clinical observations. At that time, nothing was known about pituitary physiology. It took at least another 15 years to describe the existence of a substance elaborated by the pituitary gland that promotes growth based on animal experiments. And it was not until 1944 when growth hormone was isolated, initially the bovine sequence, and then in the 1950s and 60s, finally the human growth hormone was isolated and characterized by Zhou Li and his team. Maurice Rabin in 1958 was a pioneer who isolated human growth hormone of cadaveric origin and reported its successful use to promote growth in a child who was growth hormone deficient. More recently, in the late 1960s, Harrison Heaney described effects of growth hormone on the adult skeleton based on experiments in dogs. And then a decade later, recombinant human growth hormone was reported. It was expressed in bacteria at that time, and then finally it became available for clinical use in 1985 in children, and then in 1996 it was finally FDA approved and became available for use in adults who are growth hormone deficient. And the advent of recombinant human growth hormone was very fortunate because in 1985 cadaveric growth hormone was removed from the market because of an association between cadaveric growth hormone use and a very severe and life-threatening illness, Creutzfeldt-Jakob disease. Let's talk about growth hormone secretion in action. Growth hormone is a 191 amino acid single-chain protein. The major growth hormone species is 22 kilodaltons and accounts for about 75% of growth hormone in circulation. There are several variants, including a 20 kilodalton variant produced by alternate splicing and other variants produced by post-translational modifications. Growth hormone is secreted by somatotroph cells in the anterior pituitary in a pulsatile manner, as you can see in the slide in the figure on the left panel. You can see that there's a limited number of growth hormone pulses through the day, mainly during slow wave sleep. Exercise also promotes growth hormone secretion. Fasting increases the amplitude and the frequency of the pulses, as you can see on the right panel of the slide. And growth hormone secretion occurs throughout life, but increases during adolescence, then declines gradually, but is still present throughout adult life and is active, as we will see. So how does growth hormone exert its actions? It binds to the growth hormone receptor, which belongs to the cytokine receptor superfamily. The figure shows the growth hormone molecule in blue, which is nestled between two chains of the growth hormone receptor, shown in green. So the receptor is dimerized before growth hormone binds to it, and then the receptor signals by activating JAK2 and STAT pathway, including multiple STAT isoforms, as shown on the slide. Quite a few years ago now, the somatostatin hypothesis was postulated, which is now known to be true, of course. And according to this hypothesis, there's another protein known currently as insulin-like growth factor 1 or IGF-1, which mediates many of growth hormone effects. So growth hormone directly or indirectly promotes postnatal linear growth. It also has effects on carbohydrate, fat, and protein metabolism, and it does have effects on the skeleton throughout life, as we will see. What about insulin-like growth factor 1? This is a single-chain protein, 70 amino acids long, 7.6 kilodaltons. It is expressed in many tissues, including muscle, liver, and bone, and it has paracrine or local effects, but also has endocrine effects as it circulates in the blood. The circulating IGF-1 is primarily of hepatic origin, and it is carried mostly by several, at least 6 binding proteins, which among other things serve to prolong its half-life and also modulate its actions. In particular, the majority of circulating IGF-1 is carried in a ternary complex consisting of IGF-1, IGF binding protein 3, and the acid labile subunit. Secretion of IGF-1 by the liver is positively regulated by growth hormone, and thus IGF-1 levels in the circulation serve as a good measure of growth hormone action. IGF-1 levels do not vary during the day and are not affected by food consumption. IGF-1 levels do increase during adolescence and then gradually decline throughout life, but they're present and are active throughout the lifespan. So let's talk briefly about growth hormone secretion and physiology. On top here you can see growth hormone produced by the pituitary gland, and growth hormone secretion is stimulated by growth hormone releasing hormone, also known as GHRH, which is of hypothalamic origin. It is inhibited by somatostatin, which is also of hypothalamic origin. There's also another peptide known as ghrelin, which is secreted primarily by your stomach and stimulates growth hormone secretion. Once growth hormone is secreted in the circulation, it goes everywhere in the body through the bloodstream and has multiple effects, as you can see, on several tissues, including anabolic effects on bone, muscle, and liver, lipolytic effects on fat, and also anti-insulin effects on several tissues, including muscle and liver. In the liver and other tissues, growth hormone also stimulates IGF-1 secretion, which in turn has multiple anabolic effects, also insulin-like effects on glucose homeostasis. And of course, IGF-1 feeds back on the hypothalamus and pituitary to inhibit and control growth hormone secretion in a classic negative feedback loop mechanism. So let's turn our attention to growth hormone deficiency in adults. In adults, growth hormone deficiency is relatively uncommon, with an estimated prevalence of 2 to 3 persons per 10,000 in the general population. It is important to consider who is at risk for growth hormone deficiency during adult life. And these are patients who have structural pituitary or hypothalamic lesions, such as tumors in the pituitary or the hypothalamus, patients who underwent pituitary surgery or radiation therapy, traumatic brain injury, subarachnoid hemorrhage, infection in the brain, including encephalitis or meningitis, and rarely idiopathic growth hormone deficiency of adult onset is possible, although that's an issue of controversy. In addition, growth hormone deficiency may be of childhood origin onset, and in children it can be a consequence of structural lesions. It can occur as a result of genetic abnormalities that lead to lack of growth hormone synthesis, or it can be idiopathic. And childhood onset growth hormone deficiency may persist in adult life in a subset of patients, or it may resolve, particularly when of idiopathic origin. So what are the features of adult growth hormone deficiency? These patients have increased central adiposity, primarily abdominal adiposity, decreased muscle mass. They also have decreased bone mass, as we will see, and increased fracture risk. Cardiac function is impaired, and as a consequence, their exercise capacity is often impaired. They also may have dyslipidemia with higher cholesterol and insulin resistance. Quality of life is often impaired in these patients. And growth hormone replacement is often beneficial in ameliorating these features of the adult growth hormone deficiency syndrome, although this will not be discussed at length today. So how to make the diagnosis of growth hormone deficiency in adults? An important message is that measuring growth hormone levels in adults in a random manner is of no diagnostic value, and this is because growth hormone levels fluctuate a lot during the day. In fact, in healthy adults, random growth hormone levels are often undetectable through the course of the day. So what about IGF-1 levels? As I already mentioned, IGF-1 levels serve as a good measure of growth hormone action. Can we use them to make the diagnosis of growth hormone deficiency? So here's a slide, and this slide shows IGF-1 levels of patients with diagnosed growth hormone deficiency stratified by their age. And white triangles show men, and filled triangles show women. And you can see that younger patients, those who are below 40 years old, generally have low IGF-1 levels below the normal range. The normal range is shown in dashed lines. However, older patients, particularly those in their 50s, 60s, and beyond, often have IGF-1 levels in the normal range. So the point is that measuring IGF-1 levels or even IGF-BP3 levels can be helpful in the diagnosis of growth hormone deficiency only in younger patients. However, particularly among patients who are over 40, up to 60% of these patients may have normal age and gender-adjusted IGF-1 levels. In addition, we need to consider that IGF-1 levels can be low in patients who have anorexia nervosa during starvation, acute critical illness, liver disease such as cirrhosis, uncontrolled diabetes mellitus, hypothyroidism, or women taking oral estrogen-containing contraceptives. However, there is a subgroup of patients in whom the diagnosis of adult growth hormone deficiency can be made on the basis of IGF-1 levels alone, and these are patients who have organic pituitary disease, such as pituitary tumor, unequivocally low serum IGF-1 levels, less than 2 standard deviations below the mean, and known deficiency of 3 or more additional pituitary hormones besides growth hormone. And here are the data. The figure on the left shows you a group of patients with pituitary disease, and they're stratified by the number of pituitary hormone deficiencies other than growth hormone. And what you can see here is the percent of patients who are growth hormone deficient based on stimulation testing. We can see from the slide that patients who have 3 or 4 additional pituitary hormone deficiencies are 96% and 99% likely to be growth hormone deficient. On the right side, we can see the IGF-1 levels for patients with pituitary disease, again stratified by the number of additional pituitary hormone deficiencies. And on the left, patients are growth hormone deficient. On the right panel, patients are growth hormone sufficient. What you can see is that among the patients who are growth hormone sufficient and have 3 or 4 additional pituitary hormone deficits, none of these patients have low IGF-1 levels. So again, making the point that among patients who have organic pituitary disease, low IGF-1 levels, and 3 or 4 additional pituitary deficiencies are extremely likely to have growth hormone deficiency, and these patients do not need any additional testing. However, the rest of the patients do need stimulation testing in order to establish the diagnosis of growth hormone deficiency. The figure on the right of the slide shows you how these results look like. Particularly the inset in the small figure shows you growth hormone levels in a population of healthy subjects and growth hormone deficient adults after the administration of insulin. Insulin, of course, will cause hypoglycemia if given in doses, in sufficient doses. And in healthy individuals, we can see that insulin-induced hypoglycemia induces rapidly growth hormone secretion. In contrast, patients who are growth hormone deficient show no growth hormone secretion after insulin administration. The left side of the figure shows you the peak growth hormone levels achieved after insulin stimulation. Healthy controls almost always show a nice response, and patients with hypopituitarism who lack growth hormone show little or no response. So you can draw a line between 3 and 5 nanograms per ml that nicely distinguishes patients who are sufficient and patients who are growth hormone deficient. So insulin tolerance test is still the traditional gold standard for the diagnosis of growth hormone deficiency in adult life, and is also used in children, by the way. However, the test is unpleasant. Hypoglycemia is unpleasant. It carries some risk, particularly in older patients who have heart disease or seizures, and it's contraindicated in that population. And for this reason, there have been other tests that have been developed that involve the administration of growth hormone, releasing hormone, GHRH, together with arginine, arginine alone, or glucagon alone as stimulus of growth hormone secretion. And this figure shows you the diagnostic cut points recommended by different society guidelines, Growth Hormone Research Society, American Association of Clinical Endocrinologists, and Endocrine Society. Different times they have issued guidelines about the diagnostic cut points advisable to make the diagnosis of growth hormone deficiency. And as you can see, that the diagnostic cut points vary between tests, and they're becoming also somewhat more stringent over time. We have now learned that in particular growth hormone secretion varies depending on body adiposity, particularly after GHRH and arginine administration, and as a consequence, the diagnostic cut points for growth hormone deficiency are now dependent on body mass index, or BMI, after growth hormone, releasing hormone, and arginine administration. In addition, recent data suggest that glucagon administration also may fail to elicit growth hormone secretion in obese or overweight individuals. In fact, in a study that was published recently, 45% out of 47 healthy control subjects who were overweight or obese failed the glucagon stimulation test using a cut point of 3 nanograms per ml. And in this population, a lower cut point of 1 nanogram per ml is advised. And these cut points can also be assay dependent, to be sure. So in summary, testing for growth hormone deficiency should be limited only to patients at risk for this condition. The diagnosis of growth hormone deficiency in adults generally requires stimulation testing. However, circulating IGF-1 levels can be diagnostic in some patients. Let's talk about growth hormone excess in adults, also known as acromegaly. This condition is fairly rare, with a prevalence of 40 to 86 cases per million population and an annual incidence of 4 cases per million. It is caused almost always by a benign pituitary adenoma that secretes growth hormone in an unregulated manner. And as you can see, it can cause bony abnormalities. The pictures are of a very famous patient. It was in fact Harvey Cushing's first patient with acromegaly, who underwent pituitary surgery by Cushing. You can see the patient before and after the diagnosis of acromegaly. There are evident bony abnormalities with a thickening of the nose and lips, and broadening of the jaw, and enlargement of the hands. In addition, acromegaly causes multiple manifestations, including headaches, high blood pressure, diabetes mellitus, heart disease, congestive heart failure, sleep apnea, colon polyps, menstrual irregularities, osteoarthritis, and as we will see, is associated with increased risk of vertebral fractures, carpal tunnel syndrome. And if left untreated or partly treated, acromegaly is associated with decreased life expectancy of the average by 10 years. So it is important to diagnose it early. So how to make the diagnosis? So first of all, single measurement of circulating growth hormone is not accurate, since growth hormone secretion is pulsatile. However, randomly measured growth hormone levels that are extremely low, below 0.3 nanograms per ml, practically exclude the diagnosis. More useful in practice is the so-called oral glucose tolerance test. During this test, growth hormone levels are measured every 30 minutes for 2 hours after administration of 75 grams of glucose, and patients with acromegaly generally will fail to suppress growth hormone levels below 1 nanogram per ml after the oral glucose administration. The precise diagnostic cut point, again, may vary between assays and has become more stringent over time, largely because of the availability of more sensitive assays. So this is a helpful test to confirm the diagnosis of acromegaly. What about IGF-1 levels? These correlate very well with clinical manifestations of acromegaly, and measuring IGF-1 is an accurate test for the diagnosis of acromegaly if measured with a well-validated assay. IGF-1 levels are stable during the day and are not affected by meals. However, the assay is technically difficult. It requires stripping the IGF-1 of the binding proteins in circulation, In the past, some of the assays did not use recombinant reference standards, and because IGF-1 varies with age, there's a need for a large age-stratified normative database for accurate test interpretation. In addition, low IGF-1 levels can be seen in patients who are starving, critically ill, patients with anorexia nervosa, chronic liver disease, women on oral contraceptives, or patients with poorly controlled diabetes. And these conditions can confound the findings of the IGF-1 assay. So in summary, randomly measured growth hormone levels are of little diagnostic value. However, measuring circulating IGF-1 levels provides an accurate diagnostic test, but the assay is technically difficult and carries many pitfalls, as we saw. Measuring growth hormone levels after glucose administration is very helpful in confirming the diagnosis of acromegaly. So let's turn our attention to the growth hormone and its effects on bone, and I will start by reminding you what bone looks like. So this figure shows you the what long bone looks like on the left. This is the femur, and on the right, a flat bone that comes from the skull. And in both cases, bone is composed of a compact, also known as cortical layer, that surrounds a core of spongiform bone, also known as trabecular or cancellous bone. And these types of bone tissue may respond differently to endocrine stimuli. So this is important to keep in mind through our discussion. At the microscopic level, bone tissue only has a limited number of cells, including osteoblasts that lay down bone matrix and calcify bone, osteocytes that are important in maintaining bone, and osteoclasts that resorb bone. So there's continuously a cycle of bone remodeling take place. As you can see on the left side of the panel, you have osteoclasts that derive from stem cells of monocyte lineage, and those resorb bone. And after the bone is resorbed, then osteoblasts that come from a different stem cell population become active in laying down bone matrix that becomes calcified, and osteoblasts then become osteocytes that are trapped inside the bone matrix that are important in maintaining the bone. And this cycle, bone remodeling, also known as bone turnover, is essential for many processes, including bone repair, among others. And this is a process that is very much dependent on endocrine stimuli, including growth hormone. So this shows you a summary of the findings of in vitro experiments and also studies from animals that highlight the effects of growth hormone and other hormones on the skeleton, on different cell populations. So you see the growth hormone coming from the pituitary, and directly growth hormone stimulates osteoblast differentiation and bone formation. In addition, growth hormone leads to IGF-1 secretion by the liver. It also leads to IGF-1 secretion from osteoblasts. Other hormones also stimulate the osteoblasts to produce IGF-1, including parathyroid hormone, estrogen, thyroid hormone, and other growth factors. And both the locally secreted IGF-1 and the endocrine IGF-1 then stimulate bone formation. They also produce rank ligand, which in turn stimulates osteoclasts to resorb bone. Also, you can see here growth hormone and IGF-1 have direct effect on the growth plates that are at the epiphyses of children and adolescents, and promote endochondral proliferation and ossification that's responsible for linear growth through childhood and adolescence. So in summary, growth hormone and IGF-1 system promotes both bone formation and bone resorption throughout life. Again, in summary, growth hormone and IGF-1 stimulate linear bone growth during childhood and adolescence by acting on the epiphyseal cartilage, also known as growth plate. Growth hormone stimulates osteoblast differentiation, and IGF-1 secreted by osteoblasts stimulates bone formation, but also stimulates the synthesis of rank ligand, which in turn stimulates osteoclast differentiation and function, and thus growth hormone and IGF-1 promote bone turnover, including both bone formation and resorption. So then, what are the consequences of growth hormone deficiency for the adult skeleton? So patients who are lacking growth hormone during adult life have decreased bone turnover, including both decreased bone formation and resorption. And this can be substantiated both by bone biopsy and histomorphometric studies, and also by measuring markers of bone turnover in the circulation. As a consequence of the decreased bone turnover, adults with growth hormone deficiency have decreased bone mass, measured in vivo as bone mineral density, most commonly using dual energy X-ray absorptiometry, also known as DEXA. And the figure shows the findings of one study of 26 untreated adult onset patients with growth hormone deficiency who show decreased bone density in the lumbar spine, that's the middle column, measured by DEXA. And also in the lumbar spine, bone density is decreased, measured by QCT, this is quantitative computed tomography. Cortical bone density is also decreased in the forearm in these patients, measured by single photon absorptiometry, as you can see. So these are the medians for bone density compared to the general population. And importantly, lack of growth hormone during adult life has been associated with an increased fracture risk. You can see that these are publications from 3 different studies, 3 different countries, wherein patients who were growth hormone deficient during adult life were compared either to the general population or other pituitary patients without growth hormone deficiency, and in all cases, the risk of fracture was significantly higher in patients with growth hormone deficiency compared to the control population. So what about the effects of growth hormone replacement in adults? Well, we have studies now that show that replacing growth hormone in an adult population increases bone density after a treatment period of at least 12 and preferably 18 months. The figure shows the findings of a randomized clinical trial during which 32 men with growth hormone deficiency were randomly allocated to either growth hormone or placebo. And you can see that in the anteroposterior spine, bone density increased by about close to 6% after 18 months. Controls showed no change. Lateral spine also showed similar increase in bone density. Controls showed a slight decline. Femoral neck, also patients with growth hormone deficiency receiving growth hormone replacement showed an increase about 3%. Again, the controls showed a slight decline in bone density, but there was no change in the radius, no increase in bone density, showing that the effects of growth hormone replacement are specific to different types of bones. A meta-analysis of randomized clinical trials of growth hormone replacement in adults extends these observations by showing that the effects of growth hormone replacement on bone density is really dependent on the duration of growth hormone replacement. The upper panel shows studies that are up to 12 months in duration, and in particular, the figure shows the difference between growth hormone and placebo. This is bone density in the lumbar spine. And you can see that most of the studies are centered around 0, and the diamond, which is the summary effect, is in fact centered at 0. The p-value is 0.703, so clearly not statistically significant. So growth hormone replacement for 12 months, up to 12 months, on the average, has no effect on bone density. However, studies exceeding this duration, typically 18 to 24 months, show an increase of bone density in response to growth hormone replacement. As you can see, the p-value is 0.021, which is statistically significant, and the diamond, which is the summary effect, clearly shows an increase in bone density after growth hormone replacement. What about long-term effects of growth hormone replacement? Here are data from Sweden, a study extending over 15 years. The left panel shows the effects of growth hormone replacement on the lumbar spine, men versus women. Men show an increasing bone density up to 10% after 15 years. In women, the magnitude of the improvement is much smaller, and it is also transient, as you can see. Similarly, in the femoral neck, men appear to show a greater benefit in bone density than women. And this is an observation that has been made in other studies as well. Let's talk briefly about the effects of growth hormone replacement in young adults who have childhood onset growth hormone deficiency that persists during adult life. Most of these studies find that these young adults who have completed their linear growth and are still growth hormone deficient may benefit from growth hormone replacement for several years in order to optimize their peak bone mass. You can see here that 3 out of the 4 studies show p-values that are significant. They show between 3 to 3.9% increase in bone density in the lumbar spine after growth hormone replacement. This is over placebo. And as a consequence, it has been recommended that young adults with persistent growth hormone deficiency of childhood onset should be offered growth hormone replacement during a young adult life, at least through their mid-20s, in order to optimize their peak bone mass. What about the risk of fracture and the effects of growth hormone replacement on this elevated fracture risk? Unfortunately, we have no data from clinical trials. However, we do have observational data, and here I'm showing you findings of an observational study of over 8,000 adults on growth hormone replacement and over 1,200 adults who were unreplaced. These had also growth hormone deficiency but did not receive growth hormone replacement. They were followed over a mean period of 4.6 years in a surveillance database. And you can see that the fracture incidence in patients who received growth hormone replacement was much lower than among those who did not receive growth hormone replacement, suggesting that growth hormone replacement is associated with a lower fracture risk. In fact, on Cox proportional hazards analysis, growth hormone replacement was protected from incident fracture with a hazard ratio of 0.688 that was statistically significant after adjusting for multiple potential confounders. So in summary, untreated growth hormone deficiency is associated with decreased bone mineral density and increased fracture risk in adults. Growth hormone replacement improves bone mineral density in adults, the effect being greater in men than women after a treatment period of at least 12 to 18 months. And growth hormone replacement appears to mitigate the increased fracture risk in adults based on observational data, but no clinical trials are available with fracture endpoints. So let's turn our attention to growth hormone excess in adults, also known as acromegaly, and the sequelae for the adult skeleton. A meta-analysis was published recently that really outlines the effects, what is known about the effects of growth hormone excess on the adult skeleton. This meta-analysis included 41 studies, over 1,900 patients with acromegaly and controls. And the findings of these studies do indicate that patients with acromegaly have increased bone formation and resorption, that is increased bone turnover based on the on bone biomarkers measured in the circulation. And these may include osteocalcin or bone-specific alkaline phosphatase as measures of bone formation, and then other biomarkers such as urine and collagen peptide serve as measures of bone breakdown. So these are all increased in patients with acromegaly. Most patients with acromegaly who have normal testosterone or estrogen levels, depending on gender, have normal bone density in the lumbar spine and actually somewhat higher bone density in the femoral neck. However, patients who have hypogonadism, both men and women, have decreased bone density in the lumbar spine and the femoral neck. And furthermore, patients with acromegaly as a group have an increased vertebral fracture risk with an odds ratio of 8.226. The figure here shows the subgroup analysis, patients with acromegaly. The top panel stratifies patients with acromegaly depending on the presence of active disease or controlled disease after treatment of acromegaly. It's easier to see the results in the panel on the right that shows you that patients with active disease have a significantly increased risk of vertebral fracture with an odds ratio of 3.3. The middle panel stratifies patients with acromegaly by gender. Shows you that men have a higher odds ratio than women of having vertebral fracture, and that odds ratio is 2.19. And then the bottom panel stratifies these patients by gonadal status. So patients with hypogonadism, men with low testosterone, or women with low estrogen have a higher risk with an odds ratio of 1.68. So they have a higher risk of vertebral fracture. So in summary, growth hormone excess in adults leads to increased bone turnover. Adults with growth hormone excess generally have bone mineral density that is normal. However, subgroup of these patients who have hypogonadism have low bone density. And acromegaly is associated with increased risk of vertebral fracture. So what are the major points that I would like you to take home? Growth hormone and IGF-1 have important actions on the skeleton throughout the lifespan and stimulate both bone formation and resorption. The diagnosis of growth hormone deficiency in adults generally requires stimulation testing. The diagnosis of acromegaly, defined as growth hormone excess in adults, relies on IGF-1 levels and can also be confirmed by measuring growth hormone levels after glucose administration. In adults, lack of growth hormone is associated with decreased bone mineral density and increased fracture risk, which may be mitigated by growth hormone replacement. Acromegaly is associated with increased vertebral fracture risk. We still have work to do. In particular, I think we need to get better with our assays, in particular assay harmonization, including both the growth hormone and IGF-1 assays ideally should be harmonized so that they're comparable across different platforms. Use of international recombinant reference standards has been recommended. Ideally, we will need randomized clinical trials in order to definitively establish a beneficial effect of growth hormone replacement on fracture risk in adults. However, such studies will be difficult to do since growth hormone is FDA approved and is also approved in Europe by EMA in adults. And finally, we need to understand what are the consequences of achieving control of acromegaly, control of growth hormone excess on the adult skeleton. So with these thoughts, I would like to end the presentation, and I'd be happy to answer any questions, and I would like to thank you for your kind attention.
Dr. Tritos, thank you so much for that informative presentation. It's now time for our Q&A. If you have any questions you'd like to ask, please do so now. Just click on that green Q&A button on the lower left. Sorry about that, there's that grandfather clock. On the lower left of your presentation window, and type in those questions into the box that appears on the screen, and click that send button. We'll answer as many questions as we have time for. If we're unable to get to those questions, Dr. Tritos will follow up via email after the presentation. So let's take a look at our first audience member questions. Looks like we have several coming in. Dr. Tritos, how would you evaluate an adult patient with an abnormal high or low IGF-1 level?
Yes, thank you. This is an interesting and important question. I would first recommend repeating the IGF-1 level, because particularly some assays may lack sufficient precision. So it's always really important to repeat the test to be sure that it is that the finding is consistent. It is also very important to understand the context in which the test was obtained. What was the reason? There has to be clinical suspicion of growth hormone excess or deficiency. The clinical context is very important. As I also mentioned earlier, IGF-1 levels are very much dependent on age, so making sure that an appropriate age-adjusted normative database has been used is essential. Please keep in mind that IGF-1 levels are affected by other factors besides growth hormone, and these include starvation, anorexia nervosa, cirrhosis, severe liver disease, that is, critical illness, uncontrolled diabetes mellitus, oral contraceptive use in women. All these factors can lower IGF-1 levels. In contrast, IGF-1 levels are higher in adolescence or during pregnancy, and sometimes in patients with glucocorticoid excess. So knowing all these factors are very important in interpreting the results. After these are considered, then we ought to think whether an IGF-1 level, does it represent, is it indicative of acromegaly? If acromegaly is clinically suspected and the IGF-1 level is elevated, then I would proceed with a growth hormone suppression test, that is a glucose tolerance test, in order to confirm the diagnosis of acromegaly, and then image the patient with a pituitary MRI before proceeding with treatment plans. On the other hand, if the IGF-1 is low and there is clinical suspicion of growth hormone deficiency, that is, the patient is at risk for growth hormone deficiency, then I would consider whether the patient has other pituitary hormone deficiencies that would enable me to make the diagnosis of growth hormone deficiency during adult life, even without doing a stimulation test. If a patient has 3 or more additional deficiencies, they have organic pituitary disease, then a low IGF-1 level is diagnostic of growth hormone deficiency. Otherwise, I would do a growth hormone stimulation test. And classically, this is the insulin tolerance test, but today we often do a glucagon stimulation test because insulin is unpleasant and can be hazardous, particularly for older people or patients with heart disease or seizures, in whom it is actually contraindicated.
Thank you for that response, Dr. Tritos. We have time for a couple more. Here's our next question, very interesting. Is there a difference in bone density response to growth hormone replacement between men and women?
Thank you for this question. This is actually a very interesting and important question. Indeed, in several, if not most, studies of growth hormone replacement in adults with growth hormone deficiency, there appears to be a difference. That is, men appear to show a greater improvement in bone density compared to women. And in some cases, it is possible or even likely that women may have been undertreated. Particularly women taking oral contraceptives require a higher dose of growth hormone in order to achieve similar IGF-1 secretion. However, even in some studies wherein women have been adequately treated, there appears to be a lesser response with regards to bone density after growth hormone replacement. So this appears to be a true biologic phenomenon, although that's still somewhat controversial, and we're still trying to understand the fundamental basis for this. It doesn't mean that women should not be treated, of course, but we have to be very careful to optimize their treatment dose in order to try to maximize the benefits in that population.
Response as well. We have time for one more question before we end today. Here's one from an audience member. Do we know why patients with acromegaly appear to be at increased vertebral fracture risk despite having normal bone density?
Thank you. This is also an interesting question. Indeed, patients with acromegaly are at increased risk of vertebral fractures, even though they have normal bone density, and this appears to be paradoxical. However, we now know that bone density is only one of the determinants of bone strength. Bone density does not measure, for example, bone quality. In fact, there are now data suggesting that bone microarchitecture, that is the fine structure of bone, is impaired in many patients with acromegaly, and this may be partly, at least, an explanation for the increased fracture risk of patients with acromegaly. So this is a very interesting question, and we have just begun to learn about why this is happening, but clearly more research is needed in order to fully understand this issue. Thank you.
Thank you, Dr. Tritos, and thank you again for your wonderful and informative presentation. Do you have any final comments you'd like to share with the audience before we close today?
Well, I would like to thank you as well as the audience for their participation. I hope that this activity has been informative and highlights some of the key issues pertaining to the effects of growth hormone and the skeleton. And I look forward to any additional questions or comments that you may have. Thank you so much.
And thank you again, Dr. Tritos. And I'd also like to thank LabRoots and Dia Soren for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through December 15th, 2017. You will receive an email from LabRoots letting you know when the webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Thanks for joining us, and we hope to see you again soon. Bye-bye.